So it really is today a true honor and pleasure for me to personally introduce Dr. George Mensah as today's Grand Round speaker. Dr. Mensah is the director of NHLBI's Center for Translation Research and Implementation Science. In other words, he leads NHLBI's strong efforts to close the knowledge action gap. His primary focus is on the application of implementation and system science to research translation gaps to maximize health impact in the prevention and treatment of heart disease, and also in the elimination of health inequities here in the United States and all around the world. A clinician scientist, Dr. Mensah received his undergraduate degree at Harvard College and his medical degree at Washington University in St. Louis. He did his training in internal medicine and fellowship in cardiology at Cornell. And his professional experience really has been varied and has included over 25 years of public health service, direct patient care, teaching, research, and has run the gamut from academic appointments at Cornell, Vanderbilt, Medical College of Georgia, and the VA, as well as the private sector CDC, where he was the first chief of the Cardiovascular Health Branch, and now the NHLBI, where he's the director of Citrus. His achievements are too numerous to mention, especially as we really need enough time to actually hear him speak to us today. He has authored over 400 manuscripts, abstracts, book chapters. I'm personally aware that he authored the WHO CDC Atlas on heart disease and stroke. He's a visiting full professor at the University of Cape Town and is a fellow of the American Heart Association, the American College of Cardiology, the ESC, and one of the key members of the Pan-African Society of Cardiology, which is something that we share. He has in the past chaired the Cardiovascular Study Group at the Global Burden of Disease Study. Above all, Dr. Mensah is someone that I know many others consider a mentor, and he's also a good friend. I think we must have met at least 10 years ago through the late and great Dr. Bongani Mayosi, another wonderful friend, mutual friend and mentor, and share a lot of the same academic interests and passions. I know personally that through every transition, I've always relied on George's advice and very astute words of wisdom. George, just before you start, I have to say that there are a lot of us who do good and who do well and who work hard in the treatment and prevention and research of cardiovascular disease. Dr. Mensah does all of those things, but most importantly, he serves as a key catalyst to make sure that this work continues beyond what he does personally here in the US and really all over the world. So I'll leave you with kind of the words that Dr. Mensah said in the Mayosi Memorial Lecture at the ESC. We already know enough to be successful in this endeavor of curing heart disease and stroke, but knowing is not enough. We must also act, and the time to act is now. Dr. Mensah.
What a wonderful introduction. I really appreciate it, and thank you very, very much. It is really a great pleasure for me to be here today. In fact, it's a privilege that I get the opportunity to present at the Cardiovascular Medicine Grand Rounds at the Yale School of Medicine. So, Dr. Velasquez, ladies and gentlemen, thank you very much for having me. Here's my disclosure slide. And as you see, I have no conflicts of interest. And perhaps more importantly, even though I've been introduced as coming from NIH, nothing I say here this morning should be seen as representing an official position of the NIH or the US government. I have segmented my presentation into 4 parts. First, just very briefly touch on the NIH mission. And as you see, that mission focuses around seeking fundamental knowledge and turning that knowledge into health. And then I want to ask the important question, how long does it take to turn that discovery into health? I will then spend most of the time on implementation science to share with you what we think it is and how it can play a crucial role in this process of turning knowledge into health. And then finish up with supporting research training, and career development. And I want to take the opportunity to congratulate the graduating trainees. This is a wonderful opportunity for you to take the knowledge that you've gained while at Yale and help spread the word. So a big congratulations to all of you. In fact, it's not only your graduating trainees that we're proud of. At NIH, we're very proud of the outstanding work that you do here. Even just looking at the very brief sampling of the science you presented at the American Heart Association scientific sessions or the American College of Cardiology, I saw that Dr. Onuma and Dr. Friedman led a grand round session that focused on a few of these. So we're really, really proud of the work being done here. It's also important to highlight that at the last American Heart Association meeting, it was a Yale professor who delivered the AHA Distinguished Scientist Lecture, and Harlan Krumhold identified the 7 ideas he had for accelerating breakthroughs in improving cardiovascular health. And I was particularly pleased that right in the middle of his list of 7, when he called for elevating and propelling implementation science. I'm here today to say that at NIH, this has been an important part of our mission. As you see on the slide, Dr. Francis Collins, about a decade ago, highlighted that implementation science is truly part of our mission. And the second message I have for you today is that it's an area that is ripe for exploration. We need your investigator-initiated ideas to help drive this and help move this forward. Within my own institute, the NHLBI, when you look at the 4 goals we have and the 8 strategic objectives, I've highlighted here in red 3 that focuses on what we're going to be talking about today. So I would encourage you, as you listen during the next 40 minutes or so, keep in mind that an important strategic objective for NHLBI is to optimize clinical research and also implementation research as objective 6, so that we can improve health and reduce disease. We also want to leverage the emerging opportunities in data science to open new frontiers in heart, lung, blood, and sleep research. And never forgetting the importance of training and career development, we want to be able to develop, to diversify, and sustain a scientific workforce that will be capable of accomplishing this mission. So 3 of the 8 strategic objectives directly speak to implementation science, implementation research, and the training and career development related to this. Now, on the NIH mission, if you were to visit the mission site, these are some of the pictures you see, including our director, some wonderful images reflecting the science and how NIH supports basic research, how we support translational research, how we support clinical research, and again, the emphasis on training, developing that scientific workforce. And we try to do all of this to maintain a balanced research portfolio to make sure that the return on investment is appropriate. I'm sure here at Yale and across academic health centers, we try to do the same thing by supporting basic translational, clinical, population science research, and participating and strongly supporting training. In all of this, I see as critical for turning all of the discoveries into health. In fact, Turning discovery into health is so important to us at NIH that it is at the cover of the NIH-wide strategic plan framework that helps us set priorities, help us enhance our stewardship roles, but importantly, help us support fundamental science and how that science drives health promotion and disease prevention, as well as finding treatments and cures. So turning discovery into health is important. Given how important that is, it's fair to ask the question, how long does it take? A year? 5 years? 10 years? It's unfortunate that we're not in real time, so I can see a show of hands. But we actually know the answer to that question. On average, it takes way too long to turn discovery into health. Larry Green published this paper showing the life of an idea as it starts into fundamental discovery work through publications, through synthesis of the evidence, through publication of guidelines we can trust, and eventually, hopefully, have an impact in real world practice, an average of 17 years. That is just way too long. Not only does it take that long, but it's also only a fraction of the scientific discoveries, 14%, that enters day-to-day routine clinical practice. We learned when I was a fellow attending the American Heart Association scientific sessions and then the ACC sessions that on average, Americans receive only about half of the recommended preventive, acute, and long-term quality healthcare findings. And the other half get it only half the time. Now, you might say, well, that was in the early 2000s. Things have certainly changed. Actually, they haven't. In spite of more than a decade of efforts, your efforts, our efforts, many efforts put into this, the clinical quality of outpatient care delivered to the American adult has not consistently improved. And that is something we need to take seriously. That is something we need to research. And that's something that we can use proven effective interventions to address today, because these deficits in care continue to pose serious hazards to the health of the American public. This is just one example from Levine and colleagues showing that when you look at recommended diagnostic testing for prevention, recommended diabetes care, recommended cancer screening, many areas you look at, in fact, the best we do is between 70-75% or so. And importantly, that really hasn't changed since 2002 and all the way to 2012. In fact, when you look at recommended specific medical treatments, as well as recommended counseling, we do far worse, around 40-50%. We tend to do a little better when you ask the question, what are the trends in avoiding inappropriate care? First, do no harm, so extremely important. Well, a little better than that, around 90%, but we all should be expecting 90 to 100%. But there are many areas where inappropriate care is still persistent. Inappropriate cancer screening, as well as inappropriate antibiotic prescriptions. All of these are examples that you know. And it leads us to think that while it's important to support more and more fundamental discovery and important to support more and more early translational research, it's just as important for all of us, for us at NIH and for you at Yale and other academic medical centers, to also support the strategies that can help us turn the best evidence we know, the promising practices that we have, into real routine day-to-day care. I'll show you only one example to demonstrate this unique opportunity that we have. And this is Suzanne Arnold looked at a fairly large contemporary US cohort of patients who had documented diabetes and documented atherosclerotic cardiovascular disease, clearly among the highest of our patients with the highest risk factors. And they looked at the use of lipid-lowering medication, cardiovascular medication, and glucose-lowering medications. And as you see here, the question is, for people who meet the guidelines for statin, if they are on any statin at all, not necessarily the appropriate dose, any statin at all, we still don't make 100%, but 87% is pretty good. But high intensity statin, which reflects some of our highest risk patients, fewer than half. When you ask the question, how about those who need or meet the guidelines for these other treatments, and really fewer than 20% get it. Same for cardiovascular medications, particularly antiplatelet or anticoagulant therapy, or the appropriate use of ACE inhibitors and other renin-angiotensin-aldosterone system drugs, about 72%. Similar story for glucose-lowering medications. But the most important thing in this slide is we all know that all these three strategies are important. You just don't do one or two. We want to do all of them. And optimal therapy, defined as meeting the guidelines for all three, was only 7%. So we have a long way to go. And the other message was, although most patients were on a statin or aspirin or other antiplatelet or anticoagulant, very often suboptimal use was the norm. This is why implementation science becomes important. So what is it, and how can it play an important role? This is our big tent of terms. Simply put, it's part of health services research. It's part of the science of the delivery of care, but it goes under many other terms. Even in this lecture, you would hear me talk about dissemination research, implementation research, implementation science. This is an emergent field, and the terms are certainly going to evolve a bit, but in general, it reflects the need to take the best evidence we have and find strategies to make sure they are available, they are affordable, they're widely acceptable, and they can lead to the endpoints that we want. Here's a brief definition of some of the terms. So implementation science is the broader context and is the scientific study of all the methods available to us that we use to promote the integration of research findings and evidence into healthcare policy and practice. It would include the research we do to develop the scientific data that can help us develop trustworthy guidelines. It includes strategies that we use to make sure guidelines are implementable. So it's really the broad field. Now, dissemination science or dissemination research, on the other hand, is specific and talks about the intent to understand how best to spread and sustain the knowledge and the associated evidence-based interventions. We try to distinguish implementation science, the much broader category, from implementation research, with the latter being the scientific study of the use of strategies to adopt and integrate proven effective interventions into clinical and community settings. So not just the hospital setting, not just the patient encounter, but also within community settings, as well as public health settings. What we're looking for is, how do we use the best evidence we have to improve patient outcomes on one hand, as well as population health? And that is the part of the tent that we are very, very interested in. So 8 years ago, when the NHLBI established the Center for Translational Research and Implementation Science, that was our mission to help advance implementation science at the Institute. We used this diagram to show where we worked, and it really focused on the last mile of what I call the road less traveled. We all know the funding and the support for fundamental discovery science, early and even mid-range translational research to take the bench work to the bedside, translation to patients, even including outpatient settings, and using some of the best strategies we have to have some of the most rigorous randomized controlled trials that will provide us the evidence, the strong evidence for promising and best practices. But at the end of the day, what we're looking for is what are the strategies that would help us turn all that science into translating it into real world settings. And that's where dissemination and implementation research comes in. That last mile is critical. And it's important for us to think of what rigorous research we can do to address that and immediately leverage the findings to improve the scenario in the United States. A few themes that I wanted to touch on is that as we design studies that would enhance sustained adherence to the best practices that we have, it's important that we look at proven effective interventions, interventions that are widely available, that are affordable, and that are acceptable to patients. That also means as we're thinking of our clinical trials or we're thinking of our other clinical studies, we must ask these questions first, not find the treatment and then figure out if patients are going to accept them. So it's really important to address these early on in the process. Many of our patients don't come with single conditions. And as we've learned in behavioral medicine and behavioral science, very often what is most successful are multi-level, multidisciplinary strategies. And we want to make sure that these strategies are informed by implementation science frameworks. I'll share with you some examples of such frameworks, and we're hoping that you would take these, you would use these, and send us your best ideas for investigator-initiated research. It's important that even right at the beginning that we prioritize community engagement and outreach to the community so that we can address misinformation and build trust and our trustworthiness. We can develop the best treatments, but if we don't have the trust of the community, if the community doesn't see us as working with them and not just using them to advance our research, then we stand the risk that even the best treatments, the best preventive strategies we find may not find a home. Really important to prioritize the community. Thinking of the challenges we face in care coordination leads us to say that we must also advance care coordination and done in a way that is very appropriate for context, appropriate for settings, and particularly taking advantage of what we're learning in new and novel learning healthcare systems. Finally, really important that we incorporate outcomes that are most meaningful to patients, not just the outcomes of interest to us. It makes a big difference when we lower blood pressure. We know those outcomes are important to patients, but we also think of the strategies available to us for lowering blood pressure, for treating heart failure, for treating arrhythmias. Do we take into account the patient's perspectives and the community's perspectives? I think we can do better and better based on the evidence we have. So about 14 years ago, back in 2013 and 2014, we really strongly emphasized that as the position of the NHLBI, that we're going to support a rigorous science that helps the development of the evidence that goes into guideline development. We certainly knew better to leave the development of the guidelines itself to the professionals like you on the front lines of taking care of patients. But we knew that that work required support. And there was also rigorous science and rigorous research that needed to be done. So this image on the right here tells us once we do evidence synthesis, we identify gaps in knowledge, and these gaps in knowledge what we're looking for and looking to you to bring us your ideas that are the innovative, investigator-initiated research ideas that hopefully we can fund, that would lead to the generation of more new knowledge, and new knowledge that can be incorporated into the evidence synthesis and help us develop better and better guidelines with time. But developing the best guidelines is simply not enough. We also need to identify the gaps in implementation, the challenges that clinicians face as part of the workflow. There is also research to be done there, and we are very interested in that. How do we identify those gaps in implementation? What are those barriers that make it challenging for clinicians to do what is the best and most promising practices? And once we know that, we really need to do the appropriate implementation research that would lead to new evidence that can be incorporated into the evidence synthesis, so that we have these ongoing virtuous cycles of new knowledge generation, but also turning that knowledge into better and better guidelines, as well as turning that knowledge into implementable guidelines that eventually leads to the best outcomes. This is the important part. On the left side is the implementation science, looking at the spectrum of evidence we have, all the way to systematic reviews of rigorous randomized controlled trials that help inform evidence and guidelines that we can trust. But we also need to use that to generate awareness and interest, not just in the clinical setting, but also do that in the public setting, in civil society, to help inform decision-making in all settings. Sharing that knowledge is critical, but most importantly, I've highlighted this, how this informs other research that you do. You don't need necessarily to be an implementation scientist to incorporate many of the things we've talked about and use implementation outcomes to inform your strategies. That is the goal. We really need to leverage what we've learned so far in dissemination and implementation research to inform clinical trial design. I'm showing you two examples of the commonly used models and frameworks that guide implementation research. The RE-AIM framework is commonly used, and it helps you ask the question even before you design your studies. How do you reach the targeted population? What are the strategies that are known to work best? And it's really important because we are all not experts in reaching Native Americans, Alaska Natives, American Indians. We are all not experts in reaching Latino and Hispanic populations and African Americans, the underserved community. How do we reach them, and how do we build these into our work? Adoption is very important. How do we develop the institutional support so that you're able to deliver the appropriate dose of your intervention? The implementation, certainly extremely important. How do we ensure that we have the right population, we have the right strategies, but how do we ensure that the intervention we're planning on delivering is appropriate and is delivered with high fidelity so that the intended outcomes can be guaranteed? And certainly maintenance. We don't want what we do to just stop after the research grant runs out. How do we put in place structural changes and structural mechanisms that can help enable sustained adaptation, sustained adoption, and sustained implementation of the efforts? I left out effectiveness because I view that as tricky. We really must begin with interventions that are known to be effective. So implementation research is not where you're taking the efficacy of an intervention or necessarily the effectiveness. Ideally, you know effective strategies that you know are not being adopted, and we want to find strategies to lead to maximum adoption, maximum sustained use, so that we can have the maximum benefit from that intervention. So effectiveness is key. And how do you know the intervention is effective? Certainly the metrics that you can use, including the clinical endpoints of interest, but those are secondary when the proposal you send in to us is an implementation application. We're looking for strategies that focus on what are the innovative strategies that take known effective interventions and put them into practice with a well-defined community that is a substantial public health importance, and what are the anticipated benefits. So the RE-AIM framework can really help address that. There are others that take several frameworks into mind and provide a simplified version of several multiple approaches that have emphasis on multiple settings. But the consolidated framework is one such example and this is one I'm showing that's been modified for study and process redesign. But there are several versions that can be used to guide your work. The important message here is there are multiple frameworks available. We encourage you to use one of them to inform your research design so that we can be clear that you are reaching the right population, you are addressing the adoption of the intervention, you are assessing the implementation, and you're looking at sustainability so that the impact isn't short-term. Several important questions are really helpful for us when we look at ideal applications that deserve to be funded. Is the endpoint you're thinking about likely to be measurable? Are there metrics that help us with that? Can the intervention be optimized for future studies? I mean, how generalizable is it? Can people really adhere to the protocol? Because if it's difficult adhering to the protocol in the research setting, it certainly will be very, very difficult in the real world setting. And importantly, can a clinically meaningful effect be measured in the ideal design? But then you move on to how would it work in the real world, and can it be used widely? But thinking about these steps much, much earlier in your process is key. So please think about implementation research early on, whether you're doing a randomized controlled trial or you're looking at other clinical studies that are likely to lead to interventions that we want used in real world. Yeah, some of the examples of the designs that enable you to focus on the implementation strategy that is being tested, as well as collecting evidence that would enable you to tell if the clinical outcome or the public health outcome can also be attained. Several different models. I know Yale is an outstanding center that teaches this, so please keep that in mind. I put this slide in here just to remind all of us that as we think of our research, there are multiple outcomes that come in mind. But the first that readily comes to mind, just given a training in biology and clinical outcomes, tend to be the clinical outcomes and the health status outcomes, the symptoms and the function and the measures of satisfaction, the quality of life. Those are all very important. There are also patient safety outcomes that, especially with the work of the National Academy of Medicine, have come to the forefront for most of us. Issues of efficiency, issues of safety, and clearly thinking of issues of effectiveness and equity, as well as making sure the patient is at the center of our process, as well as the timeliness of all of these. But very often, we don't go far enough. And that's part of the reason why a lot of our work gets lost in translation. We also need to think about the feasibility of the interventions, whether it's the feasibility of what we're asking patients to do, or the feasibility of what we're asking clinicians to do in a busy practice. What's the fidelity with which these interventions and these strategies can be followed? What is the reach? And particularly, are we addressing the community of interest? And then thinking about issues of sustainability, the uptake and cost. But this is a wonderful model that Enola Proctor and colleagues put together that can be very, very helpful. So as you ask the question, what can be done? How can we do it? It really helps to include as a central focus the implementation outcomes. That's when you get closer and closer to implementation research that we want to be able to support. This is an example of what NHLBI emphasized and supported during the last round of the American College of Cardiology and the Heart Association clinical practice guidelines, a very strong focus on the implementation science aspects of it, making sure that the guidelines that go out are implementable, and thinking of different strategies that can be used, what works and what doesn't. For example, very often we think of using reminders, we think of educational outreach visits to practicing physicians. We think of audit and feedback to see if we can have an impact, move the needle. We think of provider incentives, and all of these have been tried in many different settings. For this particular study, Wiley Chang and Tom Pearson and colleagues looked at the process of care outcomes as well as the clinical effectiveness outcomes for these four important examples. And what they found was, in general, reminders and provider incentives had very, very mixed effectiveness, or generally were ineffective. What was effective and important were using audit and feedback and educational outreach visits. So having trustworthy guidelines, having fairly simplified guidelines that we can trust, and using audit and providing that feedback to clinicians can go a very long way to making big differences. Recently, Ross Branson and his colleagues at WashU published this paper that highlighted another crucial role that implementation science can play, and that is helping address health inequities by using implementation research to address not just the quantity and quality of the work that is done, but also the effort and the effects, and thinking of the equity questions. So how much of a program was delivered, the individuals who were served of an underserved community, the number of stakeholders involved, the number of policies that the work led to, and how effectively and equitably was the program delivered. It is not uncommon for an effective program to be delivered in such a way that it actually worsens health disparities. We have excellent examples of currently available polygenic risk scores that, because they perform so much better in European descent populations, that when you apply it generally, you end up worsening disparities. We need to do better as part of implementation research to look at strategies that can get us closer to how we can advance health equity. So building our studies and our strategies so we can answer the question, did equity improve? How much change really occurred? Looking at effect size of disparities at the beginning, as well as improvement for both disadvantaged as well as the advantaged groups is critical. Arlene Brown at UCLA had a wonderful paper that showed that when you look at some of the simplest metrics we have in cardiovascular medicine, Life Simple 7, for example, and look at the disparities that existed about a decade ago, I believe, and to now, the first findings were that the disparities had actually narrowed, which seemed like a good thing. But the disparities narrowed because things were getting worse in whites. We want to make sure that we ask the appropriate question. We want things to improve in all populations, but the populations that have been disproportionately impacted, we want to accelerate the uptake of these interventions so that we can actually see the reduction and the elimination of disparities. I was particularly intrigued when I saw this publication from Access Health Connecticut, talking about Hartford and West Hartford, I believe, and two individuals and how different their lives were based on their social and environmental circumstances. It's really important that when we look at our designs, in addition to engaging communities, that we also take into account the social and environmental determinants. There are now some evidence to suggest that some of our risk scoring and some of our risk markers can be improved by including markers of community deprivation, markers of the metrics of joblessness. Extremely important that we devote attention to social determinants of health. And implementation science provides the opportunity to incorporate these social determinants into our work. As one example, we did a workshop a couple of years ago, published in 2018, looking at how to reduce cardiovascular disparities through active community engaged implementation research, one that incorporates social determinants of health, as well as some of the interventions that we knew were proven to be effective, that we knew would be widely available, that we knew would be acceptable, and especially by identifying what constituted the high burden communities where our work would have the biggest impact. And then making a commitment to using those best practices in the community, with the community as partners to begin to really move the needle. In fact, alignment of community partners and the types of care networks as a critical piece that we haven't leveraged as much as we could, and we're hoping that we would in the future. But in all of this, incorporating novel research methods, evaluation milestones, and making sure that we can actually measure and determine the level of disparities that existed, and that we're actually making a difference in everyone. Everyone is improving, but those disproportionately impacted are improving at a faster rate so we can eliminate disparities. Number 6 is critical because we need to provide a basis for supporting the future generation, the next generation of implementation research investigators so that we can continue this work. This is an example of a funding opportunity and an initiative that resulted from that workshop. Now we have the opportunity to support research in 7 areas with the Courtney Center at UNC that is specifically looking at how we bring together these strategies to address cardiovascular, particularly heart disease and lung disease risk, 2 of the important missions of the NHLBI. I want to close by spending a little bit of time on how we at NIH, but also you at Yale and other academic health centers can really do even better to support research, to support research training, and to support career development in implementation science, because this is one sure way to make sure we can maximize the return of the investments we've made in fundamental discovery, as well as translational, clinical, and population science. This and the next slide is just to remind you that all the mechanisms we use to support research at NHLBI are available to you. And it's best when you have an idea, just send us your 1-page concept, and we will help guide you as to which of these mechanisms that use a pay line would be most appropriate to do the investigative research that you like to do. What to keep in mind is, even when your application doesn't make the pay line, because Dr. Collins has said implementation science is a priority for us at NIH, and Dr. Gibbons has said it's a priority for us at NHLBI, we find ways to select and fund meritorious applications that maybe miss the pay line, but can make a difference because we are not funding enough in that area. I think that's important for you to keep in mind. There are also research grant mechanisms that don't use the pay line. We use what we call the zone of consideration, that if you have a meritorious application that falls within this range, we certainly do our best to look out for outstanding applications that are also addressing areas that we don't already address well enough. So that concept of a program balance becomes very important. That's why I strongly encourage you to consider implementation research if you are not considering it already. But more important than research applications, it can go a very long way in helping bridge that gap and bring the best science that we've developed, bring it that closer to a routine day-to-day care for the maximum health impact. This is just to summarize specifically for those of you who are clinical trialists. As you know, our clinical trial development continuum goes all the way from fundamental discovery through early and late translational research to implementation science. And those that are most particularly relevant tend to be the mechanisms that I've listed to the right here. But again, if you're not sure, send me an email and I'll help direct you to the right program officials and project scientists who can provide you the technical assistance you need to do your work. But in general, as you know, the parent arrow one, when you're thinking about early phase clinical trials, particularly mechanistic studies that can help us understand the best ways to leverage implementation research. Certainly the cooperative agreement mechanisms, the UG3, UH3, as well as the U24 for coordinating centers to help coordinate this work. The R61, R33, we're using more and more increasingly. Certainly those who are at the level where you're thinking of clinical trial pilot studies, the R34 helps. Most of you know these very, very well, but for those who don't, you don't need to be an expert at the mechanisms. Just send us a note and we would connect you and let you know what are the options. I want to say how proud we are of the K-12 Implementation Science Program, and we're delighted to say that of the 10 programs we currently fund, that Yale is one. We have great expectations of these programs, and we're looking to the future where we can provide even more support. But we know that we can't do it alone. So academic health centers across the country certainly can help by providing the support, providing the career development and the opportunities so that our trainees can see these as useful avenues for them. Just a shout out to the Yale Center for Implementation Science. We know of the wonderful work that's being done. If within other parts of medicine you don't have a partner here, I would encourage forming those partnerships. We look very favorably to multidisciplinary, cross-disciplinary approaches in developing innovative research applications. Certainly the Center for Methods in Implementation and Prevention Science at the School of Public Health is another important area of discipline. Dr. Dana Spiegelman and I had a conversation at one of our global health meetings in Kathmandu, and riding on the bus from that session, thought about an idea that led to a workshop that is now in progress to be published. But there are very important ethical questions in implementation research that I haven't touched on, and other areas in implementation science that deserve rigorous study, and I hope that you take us seriously on it. Finally, we need to find ways to leverage the data science advances we've made to improve our implementation research and improve how we turn knowledge into practice. I will remind you of this publication that begins to give some examples on how we use predictive analytics to galvanize the work in implementation research. And if you haven't seen it, I'll encourage you to take a look. There are several resources that are now available that were not 10 years ago, and please take advantage of it. NHLBI is also not the only place where outstanding implementation science is being done. In fact, we strongly encourage you to look at other institutes and centers. We call that using other people's money, and we strongly encourage it. But it's not uncommon to see applications come in that leverage resources and expertise from other institutes and other centers. So let me finish by just making a few conclusions. All of you, including your graduating trainees, should be very proud of the scientific discoveries you've made here at Yale and what you've contributed to cardiovascular medicine. However, I'm also here to say that on average, it takes way too long to turn those discoveries into health. And much of the discoveries we know is still lost in translation. We need to fix that. And the way to fix it is to really support implementation research with your ideas, your innovative proposals for research, as well as developing strategies for rapid integration of those interventions we know are effective and get them into routine day-to-day care, but not just in practice, but also through your professional associations, you can get them into health policy. Implementation science is crucial for doing this and for turning discoveries into health. I've also shown you it can help in advancing health equity. And finally, the related training and career development, much, much needed. I want to give a special thanks to my colleagues, David Chambers, who's Deputy Director for implementation science within the National Cancer Institute, and Dr. Kate Stoney is our Deputy Director for implementation science within the NHLBI. And thank you very much, and I will stop here. I'll turn it over to you.
Maybe I'll start, George. Thank you so much for a wonderful discussion, and we've been, I have certainly looked to your guide, Lodestar, through my own career and my own development, even though we have not met each other very often. So thank you once again. I have a couple of questions, but before I do that, I just wanted to shamelessly pitch the fact that thanks to the wonderful support of CITRIS, Don Spiegelman and I are now able to initiate a T32 in implementation science here at Yale, which we are in the midst of starting to recruit our first class, and very excited and look forward to your guidance through that program. My question to you relates to whether you have any recommendations from your experience on how to strengthen the relationships and the scientific discourse between our T0 to T3 investigators and our T4 investigators. We're fortunate here at Yale to have over 100 faculty in cardiovascular medicine, and I see my role as that individual who tries to develop synergies between different individuals who are working in different spheres. So any guidance on what you've done at the Institute to do that and to really make sure, as you've said, that the implementation research actually is impacting the constructs or impacting discovery science as well as later stage science?
Thank you very much for the question. It's a very important question, and I must admit, it's a challenge for us also in the funding agencies, and specifically at NIH. There's always that tension between basic science, early translational work, and the late stage work and implementation science. I think what we found to be most helpful is first, rather than beginning with how we divide the pie and how I need to get a bigger pie, we should all help grow the pie and get more support for research. And the second part that has also been helpful is one of the best ways to realize the impact and the return of investment in the fundamental discoveries is seeing that this work is getting done and is translating into real health impact. And so it's really a dialogue. And I'm a strong supporter for basic science. And sometimes I volunteer and sit on the early fundamental work and early translational work. Sitting in, participating in recruiting the scientific director for the Genome Institute. That is the last institute you think about. We'd be thinking about implementation science, but it's critical. So that partnership is important. And we need to demonstrate that collectively we grow the pie, and implementation science is an important way to demonstrate the impact and the value of the research that we do.
Go ahead, Dr. Lampert.
Thank you, Dr. Mensah. That was a fabulous lecture. I have a very specific question. I was really surprised by what you said about reminders not being effective. And, part of the promise of like EPIC and EHR in general is that, we're going to generate all these advisories that we're going to incorporate. Do you think that is still worth pursuing, or do you think tell me more about reminders?
I wish we had a whole lot more time to discuss it because I think it's important. I would not, as a blanket statement, completely ignore reminders. I think it's the context that's important. Just a simple reminder by itself, most of the studies have shown have not to be that effective. I give a very good example of a recent publication about influenza vaccination. Just sending a reminder multiple different ways, 2 weeks before the appointment, a week before the appointment, 3 days before the appointment, did not seem to make a difference. But sending a reminder that said, a flu vaccine has been reserved for you. Combining that behavioral nudge strategy made a huge difference. So I think it would be wrong to say reminders don't work. In that setting from Wiley Chan's study, yes, reminders were found to be generally ineffective, but I think that's taken out of context. Put within the right context, it can make a difference. You and I also know that when you get the same reminder 4 or 5 times, we have a human tendency to turn that reminder off. So we need to be creative in ways in which we use reminders.
Thank you.
Dr. Zared, I'll let you ask the final question here.
Well, thank you for a wonderful talk. One of the things that I've noticed over the decades is that there's often a real conflict between the providers of healthcare, new data, and their own financial interests. And we can see that in many, many areas. Has the Institute approached this in terms of innovative research to really look at this particular problem, which I think is a very real one, particularly in cardiology?
Dr. Zared, thank you very much for that question. And the answer is yes. The NIH takes this very seriously. And in fact, we go beyond that. It's not just financial conflicts that can be important. Sometimes there are scientific conflicts that can be very important. And so the whole broad area of scientific integrity we take as important as safety, because if you lose either, you lose the potential benefit of the science that you're doing. And we're very fortunate to have a terrific person who's heading this effort, Mike Lauer, whom you know. Mike, leading the Office of Extramural Research, takes scientific integrity very, very seriously. And those financial conflicts of interest, as well as other conflicts, are part of that work.
Thank you.
Dr. Mensah, I really would like to thank you so much for, first of all, an excellent talk. I have lots of questions, but we might have to save that for offline, but to thank you for spending the hour with us today for an excellent talk. As always, generating a lot of knowledge, a lot of information, but also, questions and things that we can ponder in future. So I thank you again, and hopefully we get to see you back here in New Haven in person, hopefully in the not too distant future. Thank you.
Dr. Onuma, thank you very, very much. And I should add, I really appreciated the time you took to look me up and what you presented. I only wish that my mother was around to hear what she said. So a real privilege. So thanks for moderating. Thanks for having me. And I look forward to accepting an invitation to join you anytime. Thanks.
Thank you. Thank you, everyone.